All right. So I'm Daniel Sherbet. I'm an interventional cardiologist here. I've been here since 2014. It's been a spectacular ride so far. We hope for many more years. What we don't have today is Dr. Lendl to entertain you up here like he did in the last lecture, but we do have Dr. Raja's hair, which I think the hospital has a separate insurance policy.
Oh, very nice. Well, thank you for that introduction. My name is Vijay Raja. I am now, I think I've been here since 2015, and actually probably now known as the other Dr. Raja. My wife has quickly enveloped my popularity despite my hair. So, well, we are going to be talking today about a new product at the time that was pretty exciting for us to be a part of and to showcase at our Heart Summit several years ago. This was early on in our training. We saw this first come to fruition and became part of our process and kind of opened and expanded a lot of the treatment options for our patients that were normally not available to be treated.
Yeah, that's very true. So we both in our training program did a lot of these cases. So it's called the Impella, and it's a what's called a left ventricular assist device that instead of being implanted surgically through the chest like the traditional ones, it's actually implanted percutaneously. So you can go minimally invasive from the leg to implant these. And when we did these in training, we were actually at a place where, though we had good surgeons, they weren't extremely aggressive. So we had a lot of patients who had severe coronary artery disease, but due to a variety of reasons, they were deemed to be high surgical risk and could not get procedures done surgically. So that was used for a lot of those patients, and it was a godsend. When I came here, I was actually surprised to find that we had surgeons who would operate on extremely high-risk patients and get fantastic outcomes. So there wasn't quite the need, as broadly as we had in training, but still, due to the volume of patients that we have, we still have a fair number of patients who still have surgical risk that is too high for them to go safely for surgery. And so that's the type of patient that we're talking about here.
As part of this process, the program has actually developed now where we have a complex conference where we talk about this, and we're able to share and kind of, as a colleague, with our surgical colleagues, present these patients, kind of decide together what the best options are, and kind of really developed a holistic approach to this whole treatment.
Yeah, it's a very congenial type of place to practice. So getting to our case, this was a gentleman, 76-year-old man who had developed progressive exertional angina, had a history of a stroke, had very severe COPD, kind of almost end-stage COPD, on oxygen, on multiple medications. FEV1 was less than 1, so it was extremely high surgical risk. And he also he had a heart that was also weakening as a result of his coronary disease. So his ventricular ejection fraction was 45%, mildly depressed. He had a nuclear study showing multiple defects. And on his cath, he was found to have severe distal left main disease. That by itself generally is an indication to do surgery, regardless of the extent of disease in most of the other vessels. But he also had severe disease in his proximal LAD, his proximal circumflex, and then he had a chronic total occlusion of his right coronary artery. So he's a very high-risk patient with severe coronary disease, has all the indications for revascularization, but you don't want to revascularize somebody with surgery who the chance of dying is very high. So the Impella ended up being a very good option for him.
So the slide actually pretty much envelops our mental Venn diagram, kind of taking the patient information, their anatomy, and their risk factors all put together to kind of determine which order we want to do this in. So,
all right. So this is what the device looks like. We're showing the pigtail kind of on the end of the catheter. And what happens is it's advanced into the left ventricle, where the part that's inside the left ventricle is able to suck up blood, and then it's ejected outside of the left ventricle into the aorta. By doing that, it actually is able to support the function of the heart. The heart acts as a pump, and so when you're doing high-risk procedures, if you can offload a lot of that work of the heart, that makes it a safer thing to do. And I think we'll show, kind of just talking about that here. It's a device that has to go through a pretty large bore sheath. So when we put it into the leg, we take special precautions in order to access the artery. We also do a lot of other things.
Sometimes it takes a little longer, but this is our for this device. This patient, you were going to do some sort of treatment that were going to be a little bit different than we normally use, or for these patients.
Yes. So the plan for this patient had very calcified vessels, which generally requires doing some type of atherectomy to kind of sand away all the calcified plaque to make it easier to implant a stent. So in addition to that, and the fact that the patient had left main disease, oftentimes what can happen is the patient may need a pacemaker temporarily during the procedure to help support the pacing function of the heart. So what you saw there was Dr. Raja putting in a pacemaker, which you can see right there, which just sits in the right ventricle, so that if for some reason the heart stops trying to beat, then we've got that. And then the next step is to get the actual Impella, the left ventricular assist device, into the left ventricle. What you're seeing here is a wire that we've advanced from the access in the leg down up the aorta, around, and then down into the left ventricle. And then over that, shortly we'll be advancing our Impella catheter itself.
So was there any challenges that you had, remember in the case that,
yes,
just as part of this process that's being sped through here, but that is now looking back, or kind of what we do forward, how we talk about these cases now and decide planning as far as these percutaneous options?
Yes, I think both of us remember this case really well because it was a live case, but he turned out to have much more severe peripheral disease than we expected, so it took quite a while to get up, and that's just one of the challenges. These patients tend to have more than one thing going on, the lungs, the heart, peripheral disease, and so oftentimes you have to kind of adjust on the fly and navigate that. So it took a little longer, but we were finally able to get the Impella advanced up. Now you see it going up the aorta. It's going to kind of come down and around and then go into the left ventricle.
So the original product had about 2.5 liters of support. Are you using the older version, or are you using more of the newer one now? Or
yeah, we are frequently using the company that makes this device has been able to increase the amount of support for the same size type device in general. So we're frequently using a little higher support, what's called an Impella CP. Regardless, even the 2.5 liter device still provides quite a bit of support, approximating what somebody can get on pump even, not quite, but approximate it to make the procedure safer. Here what we're doing, we're actually getting started with the procedure, with the coronary intervention. So we've got a catheter that we've advanced. You can see on the left-hand panel, we're advancing it from the leg and using it to engage the coronary artery. You see our arteriogram here in just a second. Our plan for this patient, like we said, is actually to do atherectomy. So we're going to put a special rotablator device that's going to help sand away a lot of the plaque, and we'll see that shortly. But you can see here, in terms of the anatomy, we've got a very severely diseased proximal LAD. Dr. Raja can point that out, for us. And the left main is also pretty severely diseased as well. You want to talk about what your approach usually is in terms of left main intervention?
So the left main is going to bifurcate in most cases, or even trifurcate with a big ramus artery. So you want to make sure that you're thinking about what your bailout strategy is. Are you going to be doing one stent? Are you going to be doing multiple stents? Are you ready to treat any of the large branches that come off? And so that's obviously part of our planning process when we did this case was what else are we going to anticipate? How quickly can we do that? And in some situations, the patient drives that more than what we plan on doing, which is what ended up happening in this case.
Yeah. So there are always unexpected challenges. This patient, we had a little bit more complex procedure planned involving the bifurcation. The patient, because his lungs were are so bad, actually had some decompensation during the case that we were also dealing with kind of off to the side, which made it fun to
Yes.
to do live.
It was good to break away. Be like, we'll be back after these messages.
So at that point, we changed to kind of a simpler strategy, which is to treat the left main and the LAD, the most important vessels, with atherectomy, and stent from the left main into the LAD, which you'll see we'll do here in a little while.
And you can tell on these radiographs, basically, that we see the calcium, the hardened plaque through this and these angiograms, and so it gives us an idea that we're going to have to do a little bit more work on these cases than standard balloon stent.
So here they're showing.
Your hands,
Yes.
very well gloved.
And you can see, yeah, it's nice that you can see the calcium even before you inject. It gives you a sense of just how calcified these vessels are.
Did you decide a certain burr on this case? I forgot.
Yeah, so burr is a reference to the actual end of the atherectomy device, the rotablator. And it's basically a little kind of ellipsoid device that has diamonds coated kind of on the front side of it. And what you do is you actually put it into the coronary, and it rotates at extremely high speed. So it's usually 170, 180,000 revolutions per minute, which if you think about it, most people should just die when you put that into the artery and rotate it at that speed, but they don't, fortunately.
It's not what we advertise.
Tele helps, and good operators help, but yeah. So you can actually do different size burrs, starting at 1.5 millimeter, going up to 2 millimeters in some patients. Usually my approach is to start pretty small, do the smallest burr, because we find that generally works pretty well to alter the lesion enough that you can get your stents in and well expanded without having to go with a really big burr. So this is actually the device itself. You're able to control it with those little hand knobs on the white part down there. And this is showing the burr. I think we're going to see it spin kind of outside the body here, if the camera can focus.
The lighting didn't help in this case, I don't think.
But what we usually do is we spin it outside the body, make sure it's working, and then we advance it all the way up into the coronary, which we'll see here in just a second. While all this is going on, and despite the fact the patient had some respiratory distress that we're also addressing, hemodynamically the patient's been very stable because he has that Impella device sitting inside the heart, helping offload the function of the heart and making it a much safer procedure.
So because of the high speed, we have basically a solution that's going to help kind of lubricate and allow a little bit more viscosity during the procedure, allow less trauma to the vessel itself, and kind of more directional treatment.
Seeing that dripping out.
This is a lot faster by doing it this way. So basically, insert the device into our catheter, going up into the heart. Kind of, Dr. Sherbet already wired the artery quickly without any problems.
That's usually the way. You know, we never have any trouble. So you see here all the devices we have: the Impella sitting, the pacemaker kind of bouncing a little bit there. The coronary wire is, you see the tip of it here. And in a second, you're going to see the rotational atherectomy, the rotablator device coming. That's that ellipsoid device that's coming out into the left main coronary artery now. We're kind of getting everything set up so that we can sand away all that plaque in the left main and I'm concentrating intensely there. All right. We actually cut kind of a lot of this video out, so it's a little jumpy. But and here you see, as we're kind of sanding, devices moving in and out, sanding all that plaque, we're using that little control knob to help us do that.
Have there been cases where you think that you've gone backwards and said, I should have used a device like this? Or?
Yes. Yeah, we call that, there's a term for that. It's called roto regret. where you regret not having used a rotablator, or there are other atherectomy devices that we use as well. There's an orbital atherectomy device. But certainly every one of us has been in a situation where we thought we could open up a vessel with a balloon and stent, but when you get in there, if it's rock hard, the balloon just cannot open the vessel up, and then you're stuck trying to deal with the consequences of that. Sometimes you're able to get through it in that case. Sometimes you have to bring the patient back for atherectomy later. But it definitely impresses upon you the importance of atherectomy, which interestingly, it's one of the earliest type approaches to dealing with the coronaries. It was done very early on, even before stents were widely used. After stents came along, it kind of fell out of favor for a while. But now that we're doing more and more complex patients, we have the ability to do procedures in patients who were high surgical risk before, but now we can use the Impella to actually do these procedures. So we need devices like the rotablator now more than ever in order to actually accomplish these procedures. And here we're kind of examining the results. So you can always get complications, obviously. One of the things we usually look for when we're puffing afterwards is little clouds of contrast coming out of the arteries, which would indicate a perforation. I think Dr. Raja has lots of experience with perforations.
We don't talk about that today.
All of us have experience with perforations. It's just part of the name of the game. So, when that happens, we have ways of dealing with it. We have covered stents we can use. We can drain some of that blood out if we need to. We have a lot of approaches to, and we have our surgeons who always back us up as well. So,
we planned on doing some imaging beforehand in the case on this originally?
Yes.
For sizing and.
So we actually did do imaging before on the diagnostic. We had used an IVUS, an intravascular ultrasound, to kind of help us size the stents. We often will use IVUS as well during the procedure. During this live case, the IVUS failed on us, though. I do remember that also from this case. So, but we already knew from what we had done before the sizing in terms of our stents. So here we have a stent that's we're covering all the disease in the proximal LAD. We're deploying that. We're going a little bit faster on this than we typically do, just because when a patient, even though the patient's doing okay, the shorter the procedure, the better. So we're speeding things along.
And that would have been very different without the support of the Impella during this case. So
yes.
I think that we were able to give us a little bit more time to work, and the hemodynamics stayed pretty stable during that time.
Actually, that's a really good point. And patients with lung disease who decompensate due to the lung disease, they have severe coronary disease and they don't have support. You typically end up with this spiral that can be very hard to deal with. And the Impella really saved us in this situation, which is why we used it. What you see right there is a little special high-pressure device that rotates and it inflates the balloon, up to 12, 14 atmospheres of pressure, which is extremely high pressure in order to open up the stent. And then you see the stent here being deployed. It's filled with contrast right now, so that you can see kind of how big it is when it goes up.
And this was where we're talking about the stenting strategy. So when we had the two vessels and in the situation, how do we initially plan and what happened to the patient during the case where we had to adapt on the fly, but basically still end up with a great outcome for the patient?
Yeah, we we always fall back on the keep it simple, stupid strategy when we need to, the KISS strategy, and that's what we ended up doing here, is stenting from the LAD down into the left main. We used a different size stent in the left main because of the size of that vessel. So we overlapped it with the stent in the proximal LAD. The patient's circumflex actually did well. I think in between there was probably a step that we did not show where we actually crossed into that and did some ballooning, but circumflex did very well, so we did not have to do any stents in the circumflex.
So with the Impella, how often are you leaving it in the case, like leaving the room with the Impella in place, or are you usually taking it out? Or?
Yeah, so what we have at the end of the case is this large bore device that's sitting in the leg, and you also have a patient who's anticoagulated, so they're will bleed very easily. So you have to decide what to do. Typically what we do is we have what we call per-close devices that are suture-based devices that we can place in the artery and deploy those sutures before we put the impella in, or deploy them partially, and then when we're done, we pull the impella out and quickly finish deploying those sutures so that you can close the vessel at the end of the case. We do that probably 95% of the time with our high-risk coronary cases. Now, sometimes in some patients, if they've become very dependent upon the impella during the case because their heart is already very sick, or that they're going to need extra support, you can actually leave an impella in for days or weeks if you need to, depending upon how you do it. And so in those situations, we can always come back later and close it and leave the impella in. This patient, we're showing the hemodynamics. We've actually got the patient's very hypertensive at this point. He's responded very well to all the pulmonary treatments, and I think here Dr. Rolifson was moderating and making fun of us, but we ended up
That's a daily
taking the
event,
impella
I
out.
think, in our case. So.
Yeah.
But excellent angiographic result. Patient, I think you're still seeing in the clinic
Yeah,
today.
the patient, interestingly, has lived for several years despite the severe lung disease, and has done very well from a cardiac standpoint also.
Which I think speaks to the case and the support that we have. These patients that have complex coronary disease and left main, the life expectancy for these patients was not abysmal beforehand, and now we have the ability to offer them things that normally we'd say medical therapy, and give them the opportunity to live for several more years without any.
That's exactly right. And I think that's something, in terms of the coronaries we've seen, in terms of valvular disease, you've seen with some of the other things we're able to do, things that patients were dying from 20, 30 years ago and more, they're not dying from now. I always tell patients who come in for our Keep the Beat, our screening program, where we find something, is if we can find something before it's a problem, there's almost nothing we can't treat or fix. And this is kind of an example of that. All right.
Questions? All right. Well, thank you.